Good evening and welcome to our celebratory event. Before we start with our celebration, I want to make you aware that by attending this event, you agree that it will be recorded and used in different media by our research communication team. This recording will not include comments in the question and answer sessions. Again, a very warm welcome to everybody who joined us tonight for celebrating 50 years of medical research between the University of Southampton and the University Hospital Southampton. Tonight, we will celebrate our asthma research study, the Wessex AsThma CoHort of difficult asthma, also called WATCH study from now onwards. My name is Dr. Hans-Michael Heitje. I'm a clinician scientist and associate professor in respiratory medicine at the University of Southampton and an honorary consultant physician at the University Hospital Southampton and co-investigator in the WATCH study. I will take you now briefly through the program for tonight. We will start with a short introduction to the WATCH study by Professor Radko Ducanowicz. This will be followed by two presentations about WATCH looking back and WATCH looking forward. We will also show you 3 short videos from WATCH study participants. After each presentation, there will be a time for questions and answer. Please be prepared and do write your questions in connection with the study into the question and answer box. It is now my great pleasure to introduce Professor Radko Ducanowicz. He is a professor of medicine at the University of Southampton with a lifelong interest in asthma. He has pioneered the research into the pathobiology of asthma here in Southampton and in international collaborations with over 250 scientific publications. Professor Ducanowicz has been a National Institute for Health and Care Research, called also NIHR, Senior Investigator, and the lead of the Respiratory and Critical Care theme within the NIHR Southampton Biomedical Research Centre. He's also co-investigator in the WATCH study. Over to you now, Radko.
Thank you very much, Hans-Michael. So it gives me enormous pleasure to kick off this meeting with a brief introduction about the WATCH study and, of course, its founder, Associate Professor Ramesh Kurukularachi, who has been a driving force behind the WATCH study and its founder. So, of course, all of you are in one way involved in WATCH, either as patients or as collaborators, as people delivering the study. So you will know a lot about it, but let me just remind you of some of the most important points. So it's 7 years old now. It has been a real source of wonderful information, scientific discoveries, and therefore it's no surprise that it has resulted in 12 really very first-class WATCH publications. It has also enabled us to obtain significant, in fact, £1 million worth of grants from charities and from other grant funding bodies. So, of course, as I said, this would not have happened without Ramesh. So let me remind you who he is. Apart from being an associate professor, of course, he is at heart a consultant physician at Southampton University Hospital Trust. So he started his research career working on a cohort of children established on the Isle of Wight who were, because they were born to parents who were allergic, they were themselves at risk of developing allergic disease. He joined at a time when this cohort had reached, I think, its 10th birthday. So the cohort is now 30 years old, so Ramesh has literally seen the members of that cohort grow up, which he then described in his PhD thesis. He's seen them go to school, become adolescents, mature as young adults, and now these same members of the cohort are having children of their own. So this has made Ramesh a foremost expert of really outstanding international reputation, and a real expert of all things in relation to cohorts. So it was natural that it was he who initiated the WATCH study by making an excellent case for why our Biomedical Research Center should support its creation and growth. And after 7 years, the WATCH cohort now, I think, has more than 500 patients enrolled. This is all fitted well with Ramesh's clinical role, and as he has led the severe asthma service for, I think, 11 years, chaired the multidisciplinary team meeting where difficult cases are discussed and important decisions are made about how they're treated. And some of you have been beneficiaries of that kind of brainstorming that Ramesh led. And so before we hand over to Ramesh, it gives me enormous pleasure to introduce our first patients who were asked to reflect on the first question, which is how their asthma had affected their life. And following this, we will hear Ramesh's presentation. Over to the video.
How has living with asthma affected my life? Gosh, in so many ways. I grew up not suffering from asthma. I didn't develop asthma until I was in my 30s. I was pregnant at the time. I kind of put it down to a hormonal pregnancy sort of thing, but then along came my daughter. She's now 21 and my asthma hasn't gone away. Through the worst periods, I was always ill. I considered myself to be an ill person who had good days. Now I'm a well person who has bad days. So yeah, asthma has affected me for a long time, but it's affecting me less and less now.
It's diagnosed as it was. To get a firm diagnosis, it was a huge relief. But the treatment at that time wasn't a huge relief. It was steroids and the inhalers I've got. So that continued. And of course, steroids, prolonged use of steroids isn't good. I felt fine half the time, but things were going wrong. So we tried to moderate that. And all in all, life was pretty grim for about 2 to 3 years from starting to feel bad with what turned out to be asthma. I think the thing that was interesting to me was that the prognosis was not particularly good in terms of continuation of medical treatment. It was good because there were biologics coming along, and I was like a candidate for those. So I was relieved to think that there was some form of better treatment coming along, and eventually that happened. So yes, I'm on the biologics now, Mindfulness.
Well, thank you very much indeed to Lucinda, Barry and to Amanda for some very powerful insights into what it is like to live a life with difficult or complex asthma. Now, it's a real pleasure for us as a research team to reflect with you really tonight on the nature of this unique study, the WATCH study, that we've been undertaking with many patients under our clinical service over the last 7 years. And WATCH is all about getting to understand better about complex or difficult asthma, just as our patients there were reflecting on. Now, my role over the next few minutes is to give you an insight into some of the background to the WATCH study and how it has moved forwards over these 7 years and what it has actually managed to find, and then give you some insights into those findings before we then start to look forward into the future as to what Watch might bring. So here is a summary of what we'll cover in the next 15 minutes or so. A little bit about why and how we started the Watch study, how the Watch study actually works, what we've started to find, and what are some of the key facts and top headlines that Watch is beginning to bring into the public domain. And there'll be an opportunity to answer some questions, but before that, at the end of my presentation, we'll return to some of our patients to hear a bit more about their experiences of living with asthma. So here's a bit of background about the Watch study and how it came into being. Here in Southampton, we have a long-standing history of delivering severe asthma care to patients from all around the south of England. And that role has grown significantly over recent years. So at the beginning of this year, in 2022, we were caring for around 1,200 patients with difficult asthma. And we're receiving a large volume of new referrals every year. So on average, just under 200 new patients come into our clinical service. And whilst many of those patients come from around Southampton, increasing numbers are coming from further afield, as you can see in this map of the south of England. And in addition to providing a service based here in Southampton, we also provide an outreach service for patients in the Isle of Wight as well. Now, there are many new treatments coming through for patients with complex asthma, the so-called biologic treatments, and we're now supervising management with biologic treatments for around 400 patients. Now, when patients come into our clinical service, they undergo extensive testing with a view to trying to characterize the nature of their disease. And here you can see a flowchart which illustrates the process that patients go through when they come into our clinic. And the patients in the audience may well remember coming into the clinic for the first time and having an extensive, very long appointment with us where they underwent many tests, including breathing tests to measure their lung function, a review with our nurses to undergo tests like allergy tests and blood tests and various questionnaires about their health, and then a rather lengthy interview with a doctor like me before their case was then actually discussed by our multidisciplinary team afterwards. And then following that, they might be referred on to other specialists who might be able to help with aspects of their health problems, but also see other members of our allied health professional team within the asthma service, like our physiotherapist or our psychologist or our dietitian. They might then undergo further tests and their treatment would be adjusted, and then they're followed up in the long term. So what that gave us was really a very well characterized clinical group of patients with difficult asthma that is being followed up long term. And that gave us the idea to establish what we call a real world cohort study within the asthma clinic at Southampton, where our ambition was to align the research participation with the clinic participation. So put simply, you come to the clinic for your clinical care, but you contribute to research through the information that's gathered at the same time. And our aim was to create a core clinical data set which would update over time and provide an ongoing vehicle for asthma research, which would both support a parent study, as you see here, but also more focused offspring studies that might look at particular aspects of basic science, the molecular pathways that drive these problems for people with difficult asthma, but also clinical research looking at the lived experience that patients have. And the Watch study began back in 2015. And it has been very successful in attracting research funding, which is not always easy to do, but as Radko mentioned, we've attracted funding from various sources, including the National Institute of Health in the United States, industry partners, and charities such as Asthma UK. And we've also, through the Watch study, established very helpful and productive research links with major research centres in the United States, but also centres in Europe and in the UK. And lots of information is coming out of the Watch study, and so far several publications have been brought out into the public domain. 12 papers are published so far, and there are many others in the pipeline. So in terms of how many patients have been enrolled in WATCH, over 500 patients have joined the study, and that was ongoing from 2015 right up until the spring of 2020, when of course something called COVID-19 arrived, and as many patients in the audience will remember, they weren't able to come to the clinic and we weren't able to undertake face-to-face visits, and that did impact on the way that WATCH operated. So we paused enrolment to WATCH at that point, but we continued to collect follow-up information from patients already in the WATCH study using the clinical data that was being collected at their follow-up clinic attendances. And now we have still over 400 patients actively participating in WATCH. And at the bottom of this screen, you can see just an illustration of the wide array of different towns and cities that people participating in WATCH come from. So what are we beginning to find about difficult asthma through the WATCH study? Well, here are some facts and figures for you. And it has to be said that the WATCH cohort is very representative of the wider difficult asthma clinic at Southampton. So we see that 2/3 of participants in the WATCH study are women. The average enrolment of patients when they joined the WATCH study was middle age, 51. And this is fascinating. Over half of the people in the WATCH study reported first developing asthma in childhood. So that means that people are having a lifelong problem with asthma in many cases. It's quite a burden to bear. And then, interestingly, we also found that over 70% of people in the WATCH study have evidence of allergen sensitization to common airborne allergens, the commonest being dust mite and other common culprits including grass pollen and pet dander such as cat that you see there. And it's very clear that patients in the WATCH cohort have very severe disease. So 1 in 3 patients in WATCH have needed to be admitted to the intensive care unit because of their asthma. 1 in 3 have required daily steroid tablets to control their asthma. And now, as we approach a new phase of asthma management with access to higher level biologic asthma treatments, over 40% of the WATCH cohort are on one of those injections. But another key finding from the WATCH study is the fact that people in the WATCH cohort do not just have asthma, they have a range of other health conditions in association with the asthma. Now, these might be other lung conditions like bronchiectasis or COPD that you see at the top of this graph here. But 2/3 of patients in WATCH have rhinitis. A similar proportion have gastroesophageal reflux. Half of patients in WATCH have obesity. And about 50% have what we call breathing pattern disorder. And over 1/3 have psychological issues such as depression or anxiety. So these other conditions are really common and potentially impactful in the setting of difficult asthma. On average, somebody in the WATCH cohort has at least 3 other health problems in addition to their asthma, adding to the burden of their health problems. Now, another key finding from the WATCH study is that there are many subtypes of asthma. Difficult asthma isn't just one condition. And a novel way in which we have looked at this within the WATCH cohort is by dividing the population according to their sex and the age of onset of their asthma. And that's what you see in this graph taken from one of our recent research publications. And what we were able to show in this sort of categorization of difficult asthma was some novel, previously undescribed types of asthma. So one group was this group here that you see here, who have early onset difficult asthma, who are women. And their disease was associated with numerous other health problems like obesity, depression, anxiety, and breathing pattern disorder. But we also found this previously undescribed group of adult onset male patients with difficult asthma who had very poor lung function, very strong inflammatory signals coming from their airways, and high treatment needs, including daily steroid tablets and biologic injections. Now, this pretty picture here is actually rather a nasty little culprit. This is a mold spore called Aspergillus, and in another recent publication from the WATCH study, we focused on patients with difficult asthma who are sensitized to mold spore, and we've shown that this is a very severe subtype of difficult asthma associated with high treatment needs, very poor lung function and evidence of significant lung damage. So something to be very wary of. A further recent paper from the WATCH study has identified that there's a predominance of a particular kind of inflammatory cell that operates in patients with difficult asthma called the eosinophil. And that's important because we now have a range of these advanced biologic treatments that can target that kind of cell. And in a recent paper, again from the WATCH study, we focused on looking at how effective some of these drugs can be. And in that paper, we looked at two drugs in particular, one omalizumab and the other one mepolizumab. And you can see here a summary figure from that paper. And what we found was that these drugs both work very well in a real-world setting, but that they tend to work on different subtypes of asthma. And response rates were reassuringly good to both drugs, ranging from 75 to 90%, but super responses were found in the minority of patients. And there are factors that can help you predict whether patients have a good response, but they're rather soft and probably not that useful in clinical practice. Now, another thing that we've done in the WATCH cohort is actually start to look at some of the molecular processes that drive difficult to treat asthma. And in a couple of recently, or one recently published study, we have looked at the cells that might drive particularly resistant types of asthma, and we have focused on cells harvested from the airways of participants who had volunteered for a test called bronchoscopy. And in that first paper that's actually been published this month, we found that there was evidence linking infections driven by a bug called Haemophilus to abnormalities in key defense cells in the airways called macrophages, which are associated with particularly resistant patterns of airway inflammation driven by cells called neutrophils, as opposed to the eosinophils I was talking about earlier. And then in another recent study that we did with collaborators in the US, again looking at samples collected from the airways of our WATCH patients, we have focused on particular immune cells called T cells. And we know that T cells are instrumental in the driving force that makes asthma difficult, and particular subtypes of T cells called Cd4 cells are really important in that regard too. And here in this rather busy but colourful graph, you can see how we have categorised the different types of Cd4 cells. Now, all you need to really focus on here are the red and the orange colours, and they actually form the vast majority of Cd4 cells that we found in this study. And this is new discovery. And what these cells are cells called tissue resident memory cells. They've not been described in severe asthma before, but they have a property of residency, as the name suggests. So they take up residence in the diseased tissue, the airway, and they sit there. And as they sit there, they exert really harmful effects, bringing in other cells as well to perpetuate airway damage and inflammation. And what we found in this study, which is yet to be published, is that they associate particularly with severe asthma, worse lung function, and are particularly relevant to those forms of asthma that seem to develop in older age, particularly in men. Now, it's not all about the cells and the molecular pathways in difficult asthma. As I mentioned in a previous slide, there are other conditions that impact on asthma. And one of the disease states that we have looked at in association with difficult asthma are psychological problems like anxiety and depression. And what we have found is that there is a significant burden of psychological abnormality in people with difficult asthma. Over 50% actually in the WATCH cohort when we have looked at it. And I wish that the slides would advance, but they don't seem to be advancing at the moment for me to be able to show you the next slide. But here we are. But you can see here a graphic from a recent paper that we have published in the WATCH cohort that shows you the the kind of burden that people with psychological comorbidities, as we call them in difficult asthma, are bearing. And you can see that as the combination of these psychological comorbidities grows, the burden that people have to carry is much greater. And another interesting finding that we uncovered from the WATCH study was that the presence of depression and anxiety seems to predict a worse response to some of the new biologic treatments. So something really of practical importance to us as clinicians. But there is light on the horizon. In another study from the WATCH study, we have looked at treatments to assist people in terms of psychological well-being and found that mindfulness approaches seem very feasible and potentially very effective for people with difficult asthma. Now, I've given you a sort of peek of the some of the findings of the WATCH cohort, and I'd just like to now close by saying acknowledgement to the many people and organisations who have helped support this study. So we have a team here at Southampton with many people who've worked extremely hard over the last 7 years, a team in the Isle of Wight as well. And then we have colleagues at various centres in the US, and then we've got to acknowledge significant support from our Biomedical Research Centre here in Southampton, and then a range of funders. But also, it has to be said, we have the participants. And what I would really like to do is just on behalf of the research team, give a huge thank you to the many patients who under our clinical service who've given their time and their effort to help us in this study. And what they have enabled us to do really is create the dawn of a new understanding about difficult asthma. And hopefully that will lead to better outcomes in the future. Now, we will be taking questions, but before that, I think it's time to hear a bit more from some of our patients.
What difference is a new treatment making to me? It's changed my life. The obvious thing is that I take a lot less steroid doses now in terms of what I take daily. I have been taking 50 milligrams, 60 milligrams a day at one point. I'm now taking either 1 or 2 milligrams a day. So it's had a big effect on that. I was always someone who was ill. I'm now someone who's well, but occasionally gets ill. I've got more energy. I have a much better outlook. I'm a more positive person because I've now got a can-do attitude rather than a, oh, I probably can't do that. So my home life is better, my work life is better. I'm positive about what I can do in the future rather than being doubtful of whether I would achieve my goals.
The new treatments have made life much more bearable and tolerable and brought me back to normal level of activity I had before. And the added advantage is that now Nepo with its can be given at home with a pen. So I do that regularly every month, and then send returns into Southampton. So in all respects, I'm living absolutely normal life, no problems at all. Routine annual checks with Dr. Dennison, but away we go. it's marvellous. I can recommend it. I wouldn't recommend asthma, I can recommend the treatment.
What's the importance of asthma research to me? It's been a game changer, a life changer. It's amazing that if it can affect lots more people. I don't want to be one of the lucky ones. I want to be one of many. It isn't just my treatment. I know there are other new drugs coming online. They need to be tested. It's given me a return to everyday life. And it's been something that's helped to develop an understanding of maybe what my disease meant to me, and also build some knowledge of how I've been affected by the drugs.
I was fortunate in the sense that when I landed up at Southampton, the research was pretty well completed on the biologics, and NIHR was looking at them, and so on and so forth. And eventually NIHR gave them clearance, and we went through the biologics that were available for my condition, and I was recommended the Mindfulness trial at Southampton with lots of other patients, and it was absolutely fine. So I'm a great supporter of research, and particularly asthma, which I think, because of the high incidence of asthma in the UK, is not given the due amount of research time that I think it warrants, because it is a disabling illness.
I want to thank Lucinda, Barry and Amanda for taking part in these videos, and thank you, Ramesh, for this excellent and clear presentation. Now we will have about 10 minutes of question and answers. Please do write your questions into the question and answer box. There's no right or wrong question, and please be encouraged to ask your questions. Let me start with the first question while people still think what they want to ask. Are there any similar studies like these around the UK and overseas? And are you working with these groups? Over to Ramesh.
Well, thanks, Hans Michael, and that's a very interesting and appropriate question. Yes, there are other studies of cohorts looking at this question about difficult or severe asthma. In terms of other cohorts and how we're interacting with them, we are actually in some collaborations with entities such as the Pan-European EuBioPred study, but also with collaborators in the US who have similar cohorts, and potentially in Australia as well. But what is quite unique about the WATCH cohort is the fact that this is an ongoing follow-up of people under direct clinical care in a clinical care setting. So that sets it slightly apart from these other studies.
Thanks very much, Ramesh. We got another question from the participants. Are there questions you are able to answer because of the size of the cohort?
Well, sure. That's again, that's an interesting question, and it may seem large, 500 people. It's not that large. You have other studies with thousands of participants, but the real advantage that is enabling us to really get down and deep on these questions about difficult asthma is the degree of testing that we have undertaken and that our patients have gone through, and that gives us a really rich amount of information about people with difficult asthma, and perhaps that is what is going to give us the real clear signals that enable us to move forward in our understanding.
Another question coming from the audience: how much of a challenge was the pandemic for this research?
Gosh, I think the pandemic was a huge challenge for all of us, whether we're doing research or not, and it potentially still continues to be, doesn't it? Yeah, I mean, I mentioned in my presentation that we had to actually pause our research in terms of enrolment to the WATCH study. And in fact, most research in Southampton had to be paused during the height of the pandemic. We're very fortunate that a lot of our key sub-studies completed just before the pandemic hits, like those bronchoscopy studies that I was talking about. So it has affected us hugely. It's affected our entire research programme in Southampton, and we're spending a lot of time and effort in getting that now back on track. But we're getting there.
Thank you very much. We got quite a few questions. There was quite a long one and a personal one, and we would ask that this question would probably be answered best in a face-to-face or personal consultation in the clinic. We have another question related to the studies. What are the mindfulness techniques that you mentioned were found to be effective? Yeah,
so what we pioneered with our psychology colleagues was a group-based mindfulness approach. So we brought together people with difficult to control asthma who had psychological stressors in their lives, and they worked together as a group with a mindfulness instructor over a period of time, as it were, attending group-based sessions over a set of weeks. And we found that this was an effective and acceptable way forwards. So it may offer a viable way forwards for some people. Of course, group therapies aren't for everyone, but it certainly looks as if that might be one option.
Okay, I think another question, and probably one of the final questions, is our slides showed high levels of depression and anxiety in the cohort. Do you know if this is getting better or worse over time?
I think what we can say is that it is a very prominent factor that's affecting the lives of people with chronic health conditions like difficult asthma. It certainly seems to be more prominent now than it was before, but that may be because we are now actually much more aware of the impact of that. Whether it's getting commoner, I don't know, but in the modern world, with all the pressures that we're living under, I wouldn't be surprised if it was.
Thank you so much, Ramesh. I think we have to end this session, question and answer session here. Thank you to everybody who asked questions and contributed to this excellent part. Now it is my pleasure to introduce Dr. Anna Freeman. Dr. Freeman is a postdoctoral NIHR clinical lecturer at the University of Southampton with an interest in asthma and exercise medicine. She has completed her training for a consultant in respiratory medicine and has recently been awarded a prestigious anniversary fellowship by the University of Southampton. She has been strongly involved in the WATCH study from the beginning. But before we hear Anna's presentation, we will have a short video about what our study participants think our asthma research should focus on excuse me, next.
What should your asthma research concentrate on next? That's a really difficult question, partly because I'm not a researcher. I suppose reducing costs, if that's a way forward, using perhaps different drugs that have the same effects. I don't know how possible that is really. Going forward, I know that asthma affects lots of people and lots of lifestyle ways. It causes depression, it stops people exercising, then there's weight gain, and it becomes a real bigger picture. If the asthma can be treated successfully earlier on, without having to wait until you've got that difficult asthma label, then that would be fantastic. I guess moving on from that, childhood asthma I know is a thing, and I know it's said that you grow out of it potentially. It would be quite nice to treat the children without having to wait for them to grow out of it, if that was possible. But as I say, I'm not a researcher, so I don't really know a true way forward. Those would be my aspirations anyway.
I couldn't be specific about that in terms of what should be done next. As I say, my research activities have always been in areas other than this, mainly large intensive care work. So my first involvement with the research was when I was enrolled into the epigenetics trial, and I watched that with great interest. So I'm not really familiar with what's going on elsewhere, except I do know there's more work being done in sort of broad context, but not in any specific granular detail. So I really couldn't say that we should go in that direction or that direction. What I've read from the preliminary work coming out of the epigenetics trial is that there are some very good markers coming out there, or appear to be, for further advances in treatment. And I'll be watching that with great interest. If I can be involved in that in any shape or form, I would be. But it's a question of really looking at that. It's a vested interest to me. I've got lots of other trials on the go, so I couldn't take anything on board more. But I would welcome being an ambassador for research in asthma.
Hello, my name is Dr. Anna Freeman, and thank you to Hans Mikkel for the introduction. And I'd also like to echo Ramesh's thanks to Lucinda, Barry and Amanda for their time and their thoughts. So my role this evening is to talk about what we're going to do next. We've heard from Ramesh about all of the exciting work that we've done so far, and we are still and constantly planning the next projects. So what are we going to do next? Is the WATCH study going to continue, or is it changing, is the next slide that we will hopefully get to shortly. Here we go. So yes, we do plan to continue with the WATCH study and ongoing follow-up, and we also plan to start enrolling new participants again. One of the things that was a side effect from the COVID pandemic is that people have developed new ways of working to make life easier for everybody to participate. And so some of the data capture will now be more automatic or automated rather than face-to-face research assessments. And to begin with, we will just do this by adapting the clinical paperwork, but in future we'll move to see if we can do it more electronically and automatically. Next slide, please. The key future focus areas for WATCH research include finding out more about the molecular building blocks for having severe asthma. What exactly at the molecular level is driving the severe asthma that some patients experience. Multimorbidity is increasingly recognised as having an influence in outcomes in terms of severe asthma, and we're working with groups internationally to try and understand that better. This is something that we're keen to explore in WATCH, and I'll tell you more about that further in the slides. We also are keen to understand more about the role of molecular building blocks and multimorbidity so that we can develop new treatment strategies for severe asthma so that patients get direct benefit from this research. Next slide, please. On the more molecular, back again, please. On the more molecular level, we are looking to understand and build on the work that Ramesh was talking about. We will start another WATCH sub-study to look deeply at the different molecular mechanisms behind severe asthma. This will go further to explore the different cell types, the ones in the red and the orange, and we will be collecting airway samples from a small number of WATCH participants, plus people with mild asthma and some with no asthma, to try and understand the differences between the groups. If anybody is interested, then a little plug here, please do get in touch and we will be looking for participants soon. Next slide, please. Understanding multimorbidity, we know from patient feedback, I think is quite key to understanding and managing severe and difficult asthma. Whilst there is the biological disease that the new medications, the mepolizumab that Barry was mentioning, can treat, there are also lots of other conditions that many patients with asthma suffer from and contribute to their symptom burden and the exacerbations and poor control that some people experience. To try to understand this better and to address it, we are developing a new multimodal intervention study so that we can support patients not only with their asthma, but also with starting or restarting exercise, with better treatments and support for other conditions like breathing pattern disorder and for depression and anxiety, and things to support patients in terms of behavioural change and adapting healthy lifestyles. Next slide, please. Next. Oh, sorry, back again. We've called this project Living Better with Asthma, and it's funded by the NIHR BRC to better understand and co-create with patients a combined exercise and emotional intervention for patients with difficult to treat asthma. We'll use personalised medicine here, so person-based approaches to support patients in adopting behavioural change and starting exercise regimes. Next slide, please. Our aims with this are, in the short term, just to understand more about the burden and consequences of having lots of multimorbidity contributing to severe asthma, as well as to create a personalised intervention. We want to understand if this is okay for people with asthma and whether it helps, and to understand the mechanisms through which the interventions might work so that we could try to use that understanding to develop an optimal intervention for patients with asthma and introduce that into part of routine clinical practice, but also to potentially use that understanding to develop new treatment targets. Next slide, please. So where we've got to so far is a year-long study where patients are supported either virtually or in person to take up an exercise training regime with appropriate support, because exercise can be quite scary when you're feeling unwell potentially already, or it makes you feel more short of breath when already you're struggling with breathing. Beyond that, we'll teach behavioural techniques as to how to integrate that into the day-to-day life, and we'll give support for breathing retraining for patients with breathing pattern disorder, and we'll continue to follow up people up to a year to see if it improves control and reduces exacerbations. So lots of exciting projects being developed within the WATCH study that we hope can increase our understanding but also have direct patient benefit. Thank you.
Thank you very much, Anna, for this clear presentation. It takes us now to our final part, which will be again about 10 minutes, and question and answers to our panel. The panel will be Radko, Ramesh, Anna, and Dr. Claire Barber, who is a postdoctoral researcher and has significantly contributed to and is strongly involved in the WATCH study. Please do write your questions into the chat room and address them to the panel for a specific person. Well, may I start with the first question to Claire? How have you been involved in the WATCH study, and what did you enjoy most?
Hi, so I've been involved in the WATCH study by taking all of the patient samples and processing them down. So I'm a big fan of sputum, and I present. Oh, sorry, am I unmuted now? It's all gone wrong. Oh, okay. Sorry.
We can hear you.
So my biggest role is processing sputum, and I'm a big fan of really looking at what's going on directly in the airways to have a good understanding of what's different in different proteins. So that's been my favourite part of the study, and I hope to use the samples that we've collected to do a lot more research and move forward with extra samples as well.
Thank you very much, Claire. A question to Radko. Do you think there will ever be a cure for asthma?
That's a really good question, but one that is difficult to respond to with certainty. I think we're always pushing our abilities to help people, to reduce suffering, to bring more normality to what we heard from the patients, that the need to exercise and so on. I recall when I was a junior doctor, there was so little we could do for people with severe asthma, but that has significantly moved forward. And of course, people listening to this or watching this symposium will also appreciate that the whole of medicine is moving forward, and that is, for example, cancer has improved, the survival rates have improved, and similarly, improvements will I'm sure be pushing our ability as we go forward. Will there one day be a cessation of asthma completely? I don't know, but we'll certainly do our level best.
Thank you very much, Radko, for this, for answering this difficult question. A question for Ramesh. It's more a clinical question. Is it common for medications to be stopped and started to monitor the patient's response?
I mean, certainly we may look to, certainly with the more advanced treatments, we obviously monitor them very closely to look at effectiveness. And increasingly we are looking at how effective are treatments, and if they're not effective, trying to stop them rather than continuing with them, because otherwise you just continue with ineffective treatments when more and more effective treatments are coming through. But that process, it very much varies from patient to patient. So I think you have to individualize the approach.
Thank you very much. Another question, maybe to Ramesh. Now, one person probably who is in biologics says, thank you so much for everything you have done to change my life and that of others. How will the treatments be rolled out to other patients in the future?
I suspect we're seeing now more and more of these biologic drugs coming through, so there's a greater choice, which enables more and more patients to access these treatments. And if we look back over the last 10, 15 years, these were the drugs of the few, and now they're becoming the drugs for the many in severe or difficult asthma. So I think what will happen is that the access to these drugs will widen. The thresholds for using these drugs will almost certainly become lower, and they'll become more mainstream treatments for patients with severe asthma in the future. But we must also look at the wider understanding, I think, for severe asthma, difficult asthma, and the fact that there are many other health conditions that people with asthma suffer from, and we ought to not lose sight of the need to address those, as Anna was saying, in the future research needs for WATCH, looking at this concept of multimorbidity too.
Thank you very much. And two short questions for Anna. What kind of exercises would you recommend to me as an asthmatic? And then probably related, how can I get in touch for the new round of research that Anna mentioned?
Thank you, Hans-Michael. So to answer the first question, it's often very personalised, and I would recommend starting gently and building up. Have a chat with your asthma nurse at your general practice or with our clinic nurses here, and we can offer sort of a little bit of advice to support that. But generally, if you're feeling well, it's very much the same as anybody else. Do a little bit, as much as you can manage, and gradually build up. So maybe for the first time, go for a 5-minute walk around the block. Next time, try for 10, and just gradually build up, and you'll be able to work out what's the right sort of level for you. For the second question, it would be great to have as many volunteers as possible, and we really appreciate your ongoing support. There's a contact email that we'll pop in the chat, so respiratoryresearch@uhs.nhs.uk, and we will absolutely get in touch with you to discuss potential research options coming up.
Thank you very much, Anna. Thank you very much to the panel. There are probably many more questions that people would like to ask, but I think we have to close this part. Thank you again to everybody who asked questions and contributed to this final questions and answer session. And at the end of our event, I want to thank you very much again for attending this session and for participating in this event, for participating in the WATCH study, and for your participation in the future WATCH-related asthma studies. Without you as study volunteers, we could not do our research of better understanding asthma and developing new asthma treatments. Thank you so much. I would also like to say a great thank you to Pei Anushana and to John Nurse from our University Hospital Southampton communication team, who organized and made this event happen. Finally, I want to point you to the links on the final slide where you can find more information and the record of the recorded videos of this WATCH study celebration as part of 50 years of Southampton research. We will also send these links to all the participants of this event. Have a nice rest of the evening and goodbye.